Hello everyone and welcome back to Clinical Cousins YouTube channel. No, we're not talking about pediatric leg joints, not those kidneys. We're talking about the first part of our nephron assembly line, okay? We're talking about the first workers in our kidneys that get access to the most rich fluid, but they are gay. No, they are not part of the LGBTQ plus community. I mean that their job is to take back. They want to reabsorb glucose, amino acids, and electrolytes, okay? GAE, gay, and they want to put out hydrogen. They want to push it out of our cells. Okay, so what do we have here? Let's draw the first part of our nephron assembly line, okay? We're talking about the proximal convoluted tubule cell. You can see I have our glomerulus. All this pre-urine is on this side. All the blood is on this side. Okay, so we have a big proximal convoluted tubule cell. We understand this. So the first thing that we have to do is we have to draw a sodium-potassium ATPase. We know that it is sucking out the sodium into the blood, putting back the potassium, and we like it. That's good. Okay, so on this side, we have the nephron tubule. Okay, the tubular side, the urine side. This is our pre-urine, as I like to call it. It's the apical side. And on the other side, we have the peritubular capillary side, which is the blood side, the sucking side. It's also called the basal side. Okay, so let's turn on our assembly line and let's see how it works out. Okay, so we know that this is sucking the sodium into the blood. It's putting the potassium inside the cell. Okay, so the blood is filtered. We just lost all of our glucose, amino acids, electrolytes, our hydrogen, our bicarb, our chloride. So this is not going to work. We need to add some more channels. We have to add some things to our tubular side. We have to add some to the urine side. Remember, our entire goal with this cell, with the proximal convoluted tubule, it is to want to bring these nutrients back into the blood. That's what it wants to do. Okay, but to do that, we have to give it some motivation, some energy. So what should we add? We should add sodium cotransporters. Remember that our cell, it's losing sodium. It wants sodium so desperately to come into our cell. So why not sneak some nutrients with it? Okay, we're all about being efficient. Some people might call it lazy, but we're going to call it being efficient. Okay, so we're going to add some sodium cotransporters. Let's add one for our GAE. Okay, G for glucose. Let's add a little sodium cotransporter here. Let's add one for amino acids. Let's add one for electrolytes. Okay, good. So we've added these things, and we know that they're sodium cotransporters. Boop, boop, boop. Sodium is going with these guys, and that is all fine and dandy. Okay, now let's run this scenario again, and let's see what happens. Okay, so this is good so far. The blood is filtering. We have the proximal convoluted tubule cell. It's sucking in the sodium. Okay, we have water. We have the glucose that's entering now. We're taking back the amino acids, the electrolytes. Okay, but now what? We have them inside the cell. We have everything that we need inside the cell, but how do we get the channels necessary to get them into the blood? Well, we have to add a few channels on our blood side. We have them in the cell right here, but now we have to get them from the cell into our blood, into our peritubular capillaries. So let's do that. Let's add some gay channels. Remember, not the LGBTQ plus community. We're adding channels for glucose. Okay, boop, boop, boop. Glucose channels, amino acid channels, electrolyte channels. Now, and also some things like phosphate. Okay, good. Now let's run this scenario again. Let's see what happens. Okay, so blood is being filtered. That's good. Now we see what happens. The sodium, the glucose, the amino acids, the electrolytes, they're all inside the cell right now. Okay, that's good. And now they're moving. The sodium potassium is providing the energy that we need. Remember, secondary active transport. And now all of these substances are now in our blood. This is good. So now we have the glucose, the amino acids, we have the electrolytes all in our cell. This is a very good thing. But we have some other things to deal with. We have to add some now. Yes, we have to worry about that stinking hydrogen and our lovely bicarbonate. So these two substances, they also get filtered. So they're in the blood, they get filtered. Now they're in our pre-urine. Okay, we've filtered all of these. We have to do something about it. Remember, our goal is to retain as much bicarbonate as possible. How can we do this? Okay, so in our pre-urine, hydrogen and bicarbonate, okay, they're filtered. They're really close, they're best buds. They decide to hook up. Who's the matchmaker? Yes, carbonic anhydrase. Okay, so these two guys, they combine. It's legal to do this now, okay? They are married, okay? So they combine to form carbonic anhydrase. Now, here's the sad part. They split up, okay? They form water and CO2 to enter our cells, okay? So now, what happens again? Well, they're got carbonic anhydrase. It just doesn't quit, okay? So these guys, CO2 and water, they actually hook up to form carbonic acid again. Now, here's the weird part. These guys will actually split up again. They can't decide. They're Kim and Kanye. They can't decide if they want to be together. So what do we have? They are now split up again. Now, what do we want to do? What was that main goal that I said? We don't want no stinking hydrogen. We want bicarb to be in our blood. Okay, so H, it's safe now. But we don't want hydrogen. We don't want that hydrogen. It wants to stay inside our nice cozy cell, but we force them out with force. Okay, so we are going to put a sodium hydrogen exchanger in here. So we are using the downhill gradient of sodium. We're sucking sodium, but we're kicking hydrogen out. We don't want no stinking hydrogen. Okay, so all of this is happening up top. Okay, the lovebirds are combining, they split up, they enter. Okay, so they turn back into hydrogen and bicarbonate. Okay, we take the bicarbonate. We love the bicarbonate. The bicarbonate is good for us. We spit out the hydrogen. This is also good. We don't want no stinking hydrogen. Okay, so now we can see we're kind of mean to hydrogen. We're kind of using hydrogen over and over and over again just to capture this sweet bicarbonate. Okay, so we can bring this bicarbonate back into our blood. Now, who's the loneliest electrolyte that we have not talked about yet? Everyone else has their lover except for chloride. Yes, table salt. Table salt is sodium chloride. We eat it every day. We use it. So isn't it so sad that it gets separated in the blood and in our nephron? Well, I have some good news for you. We are going to get chloride back into our blood where it belongs, and there's a way to do it. Okay, so let's make a little channel on our blood side. It's a little chloride channel. So we have to get chloride to this channel so that we can get it back into the blood. Okay, so a chloride channel so that it can be sucked back into the blood. We already know this. We already know that we want chloride back in our blood. Now, what if I told you that we have a nasty formate anion to get rid of? Okay, so I know. We have an anion we want to get rid of. We have an anion that we want. I know, let's exchange it for chloride. So formate out, and we want chloride in. Okay, green is in. We want chloride in. Chloride. Now we can get chloride in our blood. Remember, this lumen is very negative. Okay, we've been taking all of these positive electrolytes this whole time. And also, we've been sucking the sodium in between our cells. Okay, so this act, this negative lumen, and the fact that sodium can enter between our cells, this actually draws sodium and water and chloride back into our blood. So not only does chloride go through channels, through the formate exchanger, it also goes in between our cells. Okay, so what is really important to know here, where are we? Okay, this is the clinical part, clinical cousins, okay? We are in the kidneys. Kidneys have about 1 million of these nephrons. These are little urine assembly lines. We are at the very beginning of that assembly line. This is called the proximal convoluted tubule. Okay, these are the first workers that make the urine. Okay, so here's what we need to know. As far as we are concerned, these workers are gay, meaning that they take all the glucose from the urine, they take the amino acids from the urine, and they take the electrolytes from the urine. Okay, GAE. Remember, gay. Okay, it's going to help you. It's a acronym. It's going to help you remember that we're taking glucose, amino acids, and electrolytes. Specifically, they take about 67% of our sodium, they take our chloride, our phosphate, and lastly, we know that they spit out that nasty hydrogen, okay, and they use that hydrogen to capture bicarbonate back into our blood because we love the bicarbonate here, okay? Now, what about those sweet patients? What do the 3 P's of diabetes, increased intracranial pressure, and altitude sickness have in common? You can understand all these because you now understand the first part, that first worker, the proximal convoluted tubule. Okay, so what happens when our diabetes patients, their blood has so much sugar in it that our workers, they can't work fast enough, okay? They hit their transport maximum. You can go learn about that in another video of ours. But our patients, they have so much glucose that it's actually spilling into their urine. This is called glycosuria. This is not normal. You shouldn't have glucose in your urine. What loves glucose? What loves sugar? Bacteria. And this is why your diabetes patients will get the frequent UTIs. Okay, they're feeding the bacteria that's around their urethras. So let's talk about diabetes. Their cells can't take the sugar, so they feel starving. They eat a lot. What is this called? Polyphagia. They're eating too much. They eat so much food that it makes their blood full of sugar. Our little nephron workers, they're good workers, but they can't move it fast enough. Their blood glucose is so high that they are actually going to spill out glucose into their urine. They're going to pee a lot. What is that called? Polyuria. Well, they just peed a lot and their blood is thick like Canadian maple syrup. So what are they going to do? They're going to drink a lot. That's polydipsia. Boom. Those are the 3 P's of diabetes, explained because we know the nephron. Now, something else. Your patient has just had a head injury. They have a lot of increased intracranial pressure. They have increased ICP. You're a good person. You're watching out for that triad. You're trying to reduce it, but it's just not working. So you give your patient some mannitol. Now, a lot of your health foods might have mannitol in it because it tastes sweet, but there's a catch. It's different than glucose. Mannitol is found in some of our favorite foods because it is a sugar, but our nephron workers, when mannitol enters, they can't bring it back into the blood because it's too slippery. So you inject your patient with mannitol, and think of mannitol as sort of like a sugar planet, okay? Planets have gravity. So it goes in to your little nephron tubules, and it uses its gravity. It's pulling all of the water and sodium with it. This makes your patient pee a ton. This is going to lower their blood volume and then lower their intracranial pressure. That's why we use mannitol for increased ICP. Now, you saved the day, but what about something else? I'm about to blow your mind again. Patients with altitude sickness. How are all these combined? We know that now. The nephron, altitude sickness. Your patient, they're breathing out too much CO2 acid, so their blood becomes alkalotic. Okay, they're losing the acid, their blood becomes alkalotic, they feel terrible. We can give them a drug called Acetazolamide, which is a carbonic anhydrase inhibitor. This will prevent our hydrogen bicarbonate lovers from hooking up, and our patient will actually lose the bicarbonate in their urine. So this will actually make their blood return to normal pH levels. This is a good thing. They're going to feel a lot better. How cool is that? Because we know just one of the nephron workers, we can see how all of these common symptoms from all these common diseases start to make sense. So, as always, thank you so much for taking the time today to learn with this, and I hope to see you again soon. And remember to like and subscribe for more content. Thank you so much.